Well, hello, everyone. We are so glad to have you here with us today. I am Aubrey Rhodes. I have the privilege of serving as the Lung Cancer Research Foundation's Executive Director. Our mission here at LCRF is to fund research for the prevention, diagnosis, treatment, and ultimately the cure of lung cancer. Research is right there in our middle name. And so our focus is to fund promising, innovative research that will help to change the course of treatment. And so I think one of the things that we try to do is really bring research and the advances to the patients. And that's a big reason why we have these sorts of calls, to really ensure that we can keep everyone informed on the latest in the science. And so today's call is one of my favorites, where we're going to be talking a little bit about some of the updates that were shared at a recent lung cancer meeting out in Santa Monica called Targeted Therapies, that's hosted each year by the International Association for the Study of Lung Cancer. They're a great group and actually have been a great partner to LCRF. We have a big research project that we'll be funding in combination with IASLC this year. So before we get started, there are a couple of housekeeping items. Just want to make sure that everyone knows we've got a couple of in-person Together events coming up. They will be very similar to this Together separately, but in person. And so if you happen to be in Tarrytown, New York, or near Chicago, we hope that you will join us. The New York event will be taking place on April 13th, and the one in Chicago is May 15th. I think we'll be sending out some details following this call so that you've got the information if you or someone you know would like to join us. Just a quick reminder, we'd like to keep everyone on mute throughout the call just to avoid any feedback. The chat will remain open throughout the call, so as you have questions, feel free to chat them in and we will try to address everyone's questions. If we don't get to them today, we will certainly try to follow up after the call to ensure that everyone's questions are answered. And so now it's my pleasure to introduce our moderator for today's call. She is the chair of LCRF's Education and Engagement Committee, Dr. Isabel Preeshagul. She's an assistant attending on the Thoracic Oncology Service at Memorial Sloan Kettering Cancer Center. And she is one of the best. And I just have to say, we are so lucky to have her here. And I'm looking forward to hearing the conversation between her and Dr. Liu.
Thank you so much, Aubrey. That was very, very, very kind of you to say. I'm thrilled to be here and equally excited to be joined by Dr. Stephen Liu and learn from him today, and of course, learn from all of you. So just a little bit of brief information about Dr. Liu, who needs no introduction, but he is an associate professor of medicine at Georgetown University and the director of thoracic oncology and head of developmental therapeutics at Georgetown Lombardi Comprehensive Cancer Center. He is a board-certified medical oncologist with expertise in lung cancer and drug development, with a specific research interest focus in the development of novel therapeutic agents and innovative combinations for the treatment of advanced thoracic malignancies. Dr. Liu graduated cum laude from Johns Hopkins University before receiving his Dr. MD at University of Maryland. He completed internal medicine residency training at the University of Pennsylvania and completed a fellowship in hematology and oncology at the University of Southern California. Dr. Liu is also the co-host of the official IASLC International Association for the Study of Lung Cancer podcast, known as Lung Cancer Considered. And we are beyond honored to have Dr. Liu as a member of LCRF's Education and Engagement Committee. Stephen, welcome to the podium today. So excited to have you.
No, thanks for having me. I appreciate it. Always good to see you, and thank you for being a guest on that podcast before. So always appreciate your insights. It's nice to see you again.
Thank you. So we have so much to dive into in the next hour and 20-ish minutes, give or take, with some questions. So I just want to give a brief overview of the general topics that we're going to talk through today, really keeping it high level and practice changing, but of course, happy to answer questions as they come into the chat. So we're going to be talking about targeted therapy, then we're going to move on to antibody drug conjugates. We're going to be talking about immunotherapy briefly, what's new in the early stage setting, and then touch upon small cell lung cancer. So let's start at the top with targeted therapy. And the areas in targeted therapy that we're really going to be focusing on are EGFR, as well as the ROS1 space. So we know that, a couple years ago, data came about based off of the FLORA study, which led to the approval of osimertinib in the stage 4 setting. And this was a revolutionary study. So, we knew right off the bat, osimertinib was the go-to drug, but still, some oncologists off the cuff, based on just their clinical sense, were giving patients osimertinib plus chemo because they felt that maybe they had a higher disease burden, or they felt that the patient maybe just needed a little more oomph, right? Sometimes you can't really, some je ne sais quoi. So understandably, a study was developed to kind of look into this space and try to decide what patients may actually benefit from chemotherapy being added to osimertinib, and this study is known as FLORA-2. Do you think you could tell us a little bit about your thoughts about this study and some of the data?
Yeah, happy to. It's a very interesting discussion, and it's one where there's not a clear right answer, so we could go on for a couple hours just about this study. To walk us back, in 2018, we saw the results from FLORA. Now, at the time, the standard of care for EGFR mutant lung cancer was TKI therapy, tyrosine kinase inhibitor therapy, but we had first and second generation drugs in that role. So erlotinib, gefitinib, afatinib, and then later dancomitinib. Osimertinib was a second line drug designed to overcome acquired resistance. Resistance was usually mediated by a new mutation in EGFR called T790M, or at position 790, threonine changed to methionine. Since osimertinib worked to overcome resistance, the thought was, what if we gave it first to prevent resistance? And when we gave that drug in the first line setting with FLORA, we saw that it was clearly a much better drug, more effective, a slightly higher response rate, but a much better progression-free survival, better CNS efficacy, and better safety. And then over time, we did see that led to longer survival. So that was our standard of care. But the progression-free survival, meaning the time until we saw progression or growth of the cancer, was 18.9 months. Now, at the time, that was almost twice as much as we saw with the older drugs. But I think everyone here can agree that 18.9 months is not a very long time, and certainly not long enough. So the thought was, how can we improve? What can we do better? If we think of the same approach, what do we use typically when osimertinib becomes ineffective? The standard today would still be chemotherapy. So what if we gave chemotherapy first? There are actually two studies that really showed the power of chemotherapy there. They were both using gefitinib. And so one was called NEJ009. It's a Japanese study. And in that study, patients were randomized to receive gefitinib or gefitinib plus chemotherapy. Giving chemotherapy increased the side effects, for sure. More blood-related side effects, more nausea, more fatigue, but it improved response rate, it improved progression-free survival, and it significantly increased overall survival. People lived longer when you started with chemotherapy. Around the same time, we saw a study from Dr. Vanita Naranha in Mumbai, India, showing the same thing. When you add chemotherapy to gefitinib, you increase response rate, you improve progression-free survival, and in that study, you almost doubled the overall survival. So in parts of the world where osimertinib wasn't available, gefitinib plus chemotherapy was really the preferred treatment. In this study, it answers the question, what happens when you add chemotherapy to osimertinib, since we don't really prefer gefitinib anymore? And FLORA-2, randomized phase 3 study, pretty big study, over 500 patients, were randomized to receive standard osimertinib or osimertinib plus chemotherapy. Now, importantly, the chemotherapy here is platinum plus pemetrexed, given every 3 weeks, followed by pemetrexed maintenance therapy, meaning it's not a little bit of chemotherapy. It is chemotherapy until it's no longer tolerated. There were studies done in Japan of brief courses of chemotherapy, and that didn't seem to improve survival. It was really the longer courses that led to better outcomes. And so in this study where you're getting chemotherapy, continuing chemotherapy, what we saw was a significant improvement in that progression-free survival. With osimertinib alone, it was about 17 months. With the combination of osimertinib and chemotherapy, it went to 26 months. So an improvement in the progression-free survival by 9 months. There were some subsets that seemed to benefit more, especially those who had brain metastases, seemed to do a little better with the addition of chemotherapy. But it also, as you would imagine, increased side effects. We saw more severe side effects. The rate of severe side effects went from 27% with osimertinib to 64% with the combination. And importantly, you also changed the lifestyle. People are now getting an infusion every 3 weeks, but it significantly improved progression-free survival. That was the primary endpoint of the study, and that led to the approval of this agent, really not that long ago. How do we sort of place this in reference to Flora alone? It is clear that giving chemotherapy keeps that regimen active longer, but what's not clear is whether that will impact overall survival. And at a very immature date, there was no difference in survival. And so if I was in this position to receive osimertinib alone, and then at the time of progression to then receive chemotherapy versus getting both at the same time, if the survival is the same between those two approaches, then the only thing that's gained by giving them together is more time with chemotherapy. That doesn't seem like a good endpoint. But we don't know what's going to happen to survival. We don't know how it's going to influence the quality of life over time. We don't know what's going to happen to resistance. It's still unfolding. This is a regimen that was just approved. So right now, it is a regimen that improves progression-free survival. I do not think it's for everybody. And I think that there can be cases where we use osimertinib alone and then move to chemotherapy. And if that leads to the same survival, I think there's a lot of value for a time being on osimertinib only. When you're on an oral TKI, you're able to see the doctor only 3 or 4 times a year. You're able to maybe sometimes forget about the lung cancer. If you're getting an infusion every 3 weeks, that it's a constant reminder. It also tethers you to the cancer center. And I park in the same garage. It's hard to get there sometimes. There's a lot of traffic. You have to take time off. Doing that every 3 weeks, I think that really changes the lifestyle. And so there are a lot of individual considerations, and this really is a decision we have to make with patients. It's a lot but I don't know what your thoughts are on Flora 2. Clearly, it's better progression-free survival, but also at the cost of more toxicity, and I think the immeasurable cost of a change in lifestyle.
Yeah, I completely echo your thoughts, and I'm so glad that you brought in the patient perspective here. I think we're just still struggling with who is the right patient for this. And there was actually a comment in the chat about PFS versus OS, since EGFR lung cancer is treated in a sequential way. Isn't PFS a more meaningful metric? And I think that is a very loaded question. I certainly don't think PFS is a surrogate for OS, right?
Yeah.
Go ahead. Yeah.
So, I mean, if we think of it this way, we'll make up a number, and let's say the survival is 5 years. We want it to be much more than that. Let's say it's 5 years with osimertinib plus chemotherapy. Well, if you get osimertinib alone and then chemotherapy alone, osimertinib alone has a worse PFS. But if the survival is the same at 5 years, would you really prefer to have more of those 5 years receiving chemotherapy if it didn't lead to longer survival? And so in that setting, survival is probably the more meaningful endpoint. PFS certainly has value, but we're not really comparing osimertinib to osimertinib plus chemotherapy. That's not really what we're asking. What we're asking is osimertinib then chemotherapy versus osimertinib with chemotherapy. Now, that's not what the study asked, and it's not how the study was designed, but I think that's the more relevant question, because in the real world, if osimertinib were to stop working, we have chemotherapy there. And I really think it's the sequence of treatment versus giving both together. So if there is zero difference in overall survival, while there is value in preventing that cancer from progressing, I think there's also value in time on TKI alone, in time without chemotherapy. Now, which of those is more important, being progression-free or sort of being chemotherapy-free? And I think that all of our values are a little different. So in a setting like this, I think it's important to just outline what we know and help patients make decisions. Now, there are some cases where I think chemotherapy is a little more likely to play an important role up front. And we mentioned some of these things early on. If the cancer is growing very rapidly, if patients are very symptomatic, there was seemingly a little more benefit for patients that did have brain metastases. And some of my colleagues have adopted to using that in that setting. But as of today, I don't think there's a wrong case to use osimertinib alone. I think that is still a reasonable option for all patients. We need to learn a little bit more about who gets added benefit with the addition of chemotherapy and who's only getting more toxicity and changing their lifestyle for no difference in long-term outcome. So still a lot of unanswered questions. I think it's good to have options, but it does make things a little bit more complicated.
Yeah, I totally agree with you. And I think I think it's very difficult when the study wasn't designed to answer the question that we actually have. But I guess just to play devil's advocate, if progression-free survival means that you are able to, let's say overall survival is the same, but you have longer time without having a painful metastasis or a metastasis that decrease your quality of life, then perhaps your time alive may be more meaningful if you have less symptom burden from progression. But the study wasn't set out to answer that. But that is something that you can discuss with your patients, I guess.
It is, you're right. And, we will expect to see patient-reported outcomes and quality of life data coming out of that trial. Here's the problem with that is, if we have patients in our clinic that we see where getting an IV medicine every 3 weeks is off the table, where patients want to be on oral therapy alone, spending time with family, planning vacations, trips, which is hard to do, as we all know, when you're getting an IV medicine. If patients really wanted that quality time on only oral therapy, they did not consent to the trial. And so those voices are not going to be heard in the PRO and the quality of life outcomes that come from those trials. They are unrepresented in those studies. And this is a case where real world data can really offer some insight. They did a survey in China comparing these regimens, not these specific regimens, but asking the question if we saw an improvement in progression-free survival, but no difference in overall survival. Would you prefer the pill alone or the pill with chemotherapy? And the majority of people chose pill alone, but not all. And so I do think it's an individual option. I'm glad the regimen is approved, and I think it's a good option for some patients, but I don't think it's wrong to use osimertinib alone. And as we both know, there are some patients where osimertinib is just the right fit, and the treatment just continues long term. And so if I have someone that's been on osimertinib for 5 years, if I had gone back in time and given that person osimertinib plus chemotherapy, 5 years later, I'd be patting myself on the back saying, look how good we did. When in reality, all I did was give that person a treatment they didn't need, change their lifestyle for the worse, and give them much more side effects. So it's hard to know exactly what the right answer is. And I don't think there's one right answer.
Yeah, I think you hit the nail on the head, and trying to pick the right person, whether it's someone with brain mets, or I know there was also a subset analysis that it seemed that patients that harbored EGFR, L858R, exon 21 alterations also may have benefited. And we know, historically speaking, perhaps those patients may have a little bit more of an aggressive disease than the typical EGFR exon 19 deleted patients.
Yeah, you're right there. And what makes it more complicated, we saw these data first by Dr. Pasiani at Singapore, the World Lung 2023. And before we had a chance to digest it, a month later, we saw the Mariposa results. And that's the frontline amivantamab, which is an EGFR MET bispecific, plus lazertinib, which is another third-gen TKI. That was compared to osimertinib, and that was also better than osimertinib, and to a very similar degree. And so now we have, 2 approved frontline options, but Mariposa, likely to be approved at some point this calendar year, will give us a third. Now, which one should we use? But I like how you phrase that. Is a lot of people ask, what is your regimen that you're going to use for everyone? But I think that whole approach is antithetical to targeted therapy. What we want is the ability to further personalize, and to choose one regimen for everyone kind of goes against the whole paradigm here. What we want is to identify who is going to get more benefit and justify the extra infusions and toxicity from either chemotherapy or amivantamab. And so we still have a little bit of work to do. We have these options. We will have more options, and it's good to have those. But this is not the finish line. This is just the start.
Yeah, I echo that, and I think I need more data to try to decide who really is the right patient for this. And we actually have a study that I know you're aware of, Stephen, called Shedders at MSK, that's basically looking at circulating tumor DNA. So basically, you have a patient that's you check their circulating tumor DNA for presence of an EGFR alteration, and then you start them on osimertinib. And after 4 weeks of therapy of osimertinib, you check for the presence of circulating tumor DNA, EGFR circulating around in the bloodstream again. And if you still have EGFR circulating around in the bloodstream, you remain on the study. And at that point, you get randomized to either get chemotherapy plus osimertinib or osimertinib alone. And I think that may be, I'm really interested to see if that is the deciding factor. And perhaps those patients at 4 weeks that still have that EGFR circulating around maybe that's the deciding factor. That means their disease is a little more resistant and they need a little more.
I agree. Yeah, I'm excited to see
Who
that.
knows?
It's a very good design. There was a question about approvals. Osimertinib as frontline therapy was approved in 2018. The combination of osimertinib and chemotherapy was approved last month, so a few weeks ago. The combination of amivantamab and lazertinib, that is not approved. And so we're still waiting for the FDA to make a decision on that, but expect a ruling probably sometime later this year.
Yes, and I think the question is asking, so what is approved in the frontline setting? And it would be either osimertinib or osimertinib plus chemo.
That's right.
If you harbor an EGFR alteration in the stage 4 setting. So we really have been sort of tickling upon amivantamab. So let's move on to the EGFR exon 20 space, which was the stepchild of the EGFR alterations for quite some time until amivantamab and then mobocertinib came about. What are your thoughts on amivantamab plus chemo? Talk to me a little bit about what your thoughts are there.
Yeah, so EGFR exon 20 was, like you said, it was a challenging subset because this is a group that did not seem to benefit from immunotherapy, but also did not benefit from just EGFR TKIs alone. And so the standard treatment for many years was only chemotherapy, which was very frustrating as sort of an antiquated form of therapy. It changed with the development of 2 targeted drugs, one of them amivantamab. That is an IV medicine that targets both EGFR and MET. It is not a chemotherapy agent. It is a bispecific antibody, and it was approved by the FDA for EGFR exon 20 in the setting of prior chemotherapy. The Papillon study was a phase 3 trial that looked to move amivantamab to the frontline setting. Now, in that study, half of the patients received only chemotherapy, and the other randomization was chemotherapy plus amivantamab. A few differences here. When you look at amivantamab alone, once you get past the initial induction, it's given every 2 weeks. In the trial, it's given every 3 weeks, which I think is a more favorable schedule. And what they showed was that when you add amivantamab to chemotherapy, it significantly improved outcomes. This was a home run result presented by Dr. Nicolas Girard at ESMO. We saw the progression-free survival went from about 6.5 months with chemotherapy to almost a year with the addition of amivantamab chemotherapy. The hazard ratio here is 0.40. What that means is a 60% reduction in the risk of progression or death. For reference, we would be encouraged by a hazard ratio that is less than 0.7. Here, 0.4, that's a home run. And so as soon as these data were presented to me, practice changed. Where available, this was, I thought, the best frontline option that's out there. And really, I have no problem recommending this in the frontline setting. There are side effects with amivantamab. The main side effects we see are related to its targets, EGFR and MET. And so you can see rash. You don't see a lot of diarrhea, but you can see rash and paronychia, the sort of brittle or blistering of the fingernails or the cuticles. The rash is a little more than I think you see with osimertinib, particularly on the scalp, upper chest, back. You can see edema or swelling of the legs. That's related to MET. And importantly, you do have infusion reactions. But a quick word on that is, I know that you're familiar with these. These are not really allergic reactions. The medicine is given through an IV. Most people, 60, 70%, will have a reaction to the first exposure. And as a result, the drug is actually split into 2 doses on the first week. And so it's given day 1 and day 2. Patient receives the medicine, they have a reaction, we stop, they recover. At our site, we just throw it away. And you come back the next day for the second dose, and it never happens again. It's given weekly for a month and then every 2 weeks. Although in this study, after that, it was given every 3 weeks, which obviously is a more favorable regimen. So there are toxicities with it, a clear improvement in progression-free survival, and I would consider that the standard of care today for an EGFR exon 20.
Yeah, I would too. I'm so tired of getting these approvals for these alterations that have really not had much attention, but being told that we can't give them until the second line setting. It's frustrating, and I know we need data to show that they're more effective than frontline therapy. But I'm so happy that we're able to do this for our patients. But I do agree, this infusion reaction is something that you really need to teach your patients about and make sure that you're aware of it. So if you have an EGFR exon 20 alteration and you're planning to get amivantamab and chemo, I would just get it in your head that you're likely going to have some kind of reaction. It's only going to happen in the chair. It's not something that's going to happen when you go home. We know how to manage this. And there's actually wonderful pre-medications that you can take days leading up to your chemo, like Singulair, and then you get steroids in the chair and a whole slew of other medications to try to decrease the severity or prevent this from happening.
Yeah, I think this is an exciting drug. It works in a couple different levels, and targeting MET might be particularly important in an EGFR mutant lung cancer because we know that for maybe 20%, MET is going to ultimately mediate resistance. And so if we can block it from the jump, maybe we can keep these drugs working longer. There are side effects, it's true, and we do want to be a little more informed on how to use it. So one of the questions in the chat was about how bioinformed use could help. And really, that's just speaking to a biomarker. There was a little bit of data, a small data set presented by Dr. Benjamin Best from Gustave Roussy, showing that really MET expression really seemed to predict response, but this is still pretty early. We're not quite there in terms of how to use biomarkers to guide the use, but we are still looking. And there is a new formulation. It's actually subcutaneous, not intramuscular, that is being developed now. And I know your institution's playing a role in that. So subcutaneous amivantamab is not going to have the infusion reactions that we see. We'll see if there are differences in overall toxicity and efficacy. Those data haven't fully been presented yet, but subcutaneous may go a long way to making this drug a little bit easier to receive.
Yes, I completely agree. And speaking of biomarker-driven decision-making, we are going to get to that in our antibody drug conjugate discussion. So great question, and hold that thought in the MET space. So I think we can move on from EGFR exon 20 and talk a little bit about ROS1, which is something we really haven't talked about in a really long time because we've basically just had crizotinib. And then it was just kind of, that was it for a really long time. So all of a sudden we have entrectinib, we have repotrectinib, and we have a very exciting study at MSK that I can talk about a little bit in this space. So can you talk to me a little bit about your experience with entrectinib and repotrectinib, how you choose between the two?
So we were involved in both of these trials, and both these drugs are FDA approved now. ROS1 is going to be in about 1% of lung cancer, and it's ROS1 fusions, not mutations. And when present, it allows for certain targeted agents. Crizotinib was approved based on the Profile 1001 trial led by Dr. Alice Shah. And what we saw there is crizotinib was a more effective agent than chemotherapy, better response rates, better tolerated. And entrectinib came along and had a little more CNS efficacy, worked a little bit better in the brain, which is important because for unclear reasons, ROS1 fusion lung cancers seem to be attracted to the brain. So we want a drug that's going to help prevent that from happening. Repotrectinib was approved in November 2023. That was based on the Trident study. The lead author was your colleague at Memorial Sloan Kettering, Dr. Alex Drillen. And this is a drug that targets ROS1 very effectively. The numbers are phenomenal, and I think that they're irrefutable. When we look here, the chance of response was about 80%. The duration of response and the progression-free survival were about 3 years. Those are medians. And we've had patients that have been on for much longer than 3 years. And so to start with 3 years compared to 19 months, which is what we see with entrectinib and crizotinib, 35 months with repotrectinib is a clear improvement. And the challenge with repotrectinib and with entrectinib is that they are not pure ROS1 inhibitors. They also target a molecule called NTRK. Now, NTRK or NTRK, NTRK fusions occur in about 0.1 to 0.2% of lung cancers. They're rare. But when they occur, we have two drugs FDA approved. Entrectinib, approved for both ROS1 and NTRK, and larotrectinib. But a drug like entrectinib targets both NTRK and ROS1, while on one hand, it's a versatile drug. And now you can use it for both targets, which may seem nice. On the other hand, it adds more toxicity. So when we block a protein signal, there are consequences if that protein is involved in normal stuff, right? So if we block EGFR for a cancer cell that's depending on EGFR, you kill the cancer cell, and that's great. But EGFR is also expressed on the skin, and that's why EGFR inhibitors cause a rash. It's also expressed on the mucosa, the lining in the mouth, on the nail beds, on the colon, and that's why we see paronychia, stomatitis, and diarrhea. because those are the consequences. That's what happens when you block EGFR in normal tissue. Now, what happens when you block NTRK? It's fascinating. NTRK is an important molecule, and it plays an important role in something called proprioception. Proprioception is the sensation of where your body is in space. And so when I hold my hand up here and I close my eyes, I know my hand is right about here. And now I know it's higher. Now I know it's lower. The same with my feet. When we block NTRK, we disrupt that sensation. And so you kind of don't know where your feet are. You kind of don't know where your head is when you close your eyes. And that translates to dizziness. Dizziness is very common with these drugs. And I'll tell you what, it can be severe. It can prevent people from walking right. You can lead to lots of falls. And I suspect it's probably underreported in the trials and in practice, in part because maybe patients are a little hesitant to report it because they don't want to stop the medicine that's working so well, in part because maybe we attribute it to something else, or maybe the doctor doesn't pick up on it because the patient is already sitting down when he sees them, and the patients maybe don't notice it, and sometimes the doctors are just too busy to spend enough time to really ask. So dizziness, I think, is underappreciated, underreported, but it can be significant. And that's what happens when you block NTRK, is you cause dizziness, falls, gait instability, or unstable walking. Other side effects? Well, NTRK also plays a role in satiety, which is the feeling of being full. And so when you're blocking NTRK, sometimes you don't feel full. And as a result, it can lead to overeating, polyphagia, or weight gain. It's not edema, it is weight gain. And we've had patients on these types of medicines that have gone from 100 pounds to 250 before we really knew what was happening. Weight can really increase a lot. Other consequences? Well, one interesting one is that NTRK is also involved in pain sensation and what we call nociception. And that's why sometimes when you stop these drugs, there's a very serious pain withdrawal. And it's important we counsel patients there. A lot of patients are left unprepared for that, but it is pretty common. And so we really need to warn patients that it can be painful when you stop these drugs suddenly, and we usually have to taper them off over a little bit of time. Now, all of those are from blocking NTRK. And if you're taking repotrectinib or entrectinib for its ROS1 blocking ability, then those are pure side effects with no benefit. If you have an NTRK-related cancer, it's going to come with it. It's called an on-target toxicity, and there's no real way around it. But for ROS1, you don't need any of those. You don't get any benefit from that. They just come because the drug is not so selective. There are two drugs that are coming along that might change this. One is called taletrectinib. Taletrectinib is a drug that still has NTRK activity, but it spares NTRK2. There are 3 different NTRKs, and so it should have less of that toxicity. And in early studies, that is what we're seeing. Again, the chance of response with these drugs is over 90%. And that one may have less toxicity. And then the other drug doesn't have a name yet. And I know that you're involved with this one and that's NVL-520. And I think you have some experience with that one, right?
And
Yeah.
I'm gonna on what?
Oh,
Research.
sorry. Judy, do you mind putting yourself on mute? Thank you. So, so yes, I think you hit upon all of the concerns that I have with these dual ROS1 and TRK blocking agents. And really the dizziness, I agree with you, I think is underreported. And this is something that can often be missed because a lot of times, as you had said, patients with ROS1 fusions present with brain metastases or develop brain metastases. So sometimes this dizziness can almost be attributed to, oh, that's just my brain mets, oh, that's just, that's just symptom burden, or I'm just fatigued, or I have anemia from chemo and I'm dizzy from anemia. So I really, anytime my patients are on these drugs, I really try to make sure that I tease that out very, very carefully. And you did bring up the NVL-520, which is a study that we have at MSK looking at patients with solid tumor malignancies that harbor ROS1 alterations. And I do think the beauty of this drug is that there's not as much NTRK toxicity, right? As you had said, like the taletrectinib use, we're seeing a lot less of the central edema that sometimes we see with the NTRK. We're seeing a lot less of the satiety. We're seeing a lot less of the dizziness. I wouldn't say it is toxicity free because it certainly is not. But I think we're realizing over and over again that blocking NTRK, when you're really just looking to focus on the ROS1 panel, is really the direction that we need to go. So I really am looking more towards this, this NVL 520. And if I have a patient that's fit for protocol harboring a ROS1, I certainly think of this.
Yeah, I agree. We have that trial as well. And there's been a little bit of data that's been publicly disclosed, what we call dose-limiting toxicities, which really prevent the drug from going higher. Dr. Drillin presented that there were no dose-limiting toxicities, unheard of. But one can imagine if you've got a drug that purely blocks ROS1, there's not a lot of stuff that ROS1 does in the normal adult body. So if you've got a drug that purely blocks ROS1, on paper, you should be able to give a much higher dose. And that much higher dose without side effects might allow the drug to, for example, work a little better in the brain, maybe work for longer overall. And so I think it's exciting, but it is early on. So we'll wait to see how the trial matures over time.
Yes, absolutely. I see a question in the chat here. Can amivantamab be used to treat patients with EGFR exon 19?
Yeah, good question. There is some data from the Chrysalis trial that does show it has activity after osimertinib. In the frontline setting, though, the combination that's really been explored is amivantamab with a TKI, with lazertinib. There's been a little experience with amivantamab plus osimertinib. There's sort of single-arm studies that have been done that look pretty similar. But the regimen that's being reviewed by the FDA is amivantamab with lazertinib in the frontline setting. In the second-line setting, amivantamab by itself has a little bit of data, but amivantamab plus chemotherapy is a regimen that's also being explored. That was presented at ESMO by Dr. Antonio Passaro from Milan, and that was called Mariposa 2. So as if these weren't confusing enough, now they all have sequels and numbers. Mariposa 2 was chemotherapy after osimertinib, and it was EGFR, DEL19, and L858R. One arm was osimertinib alone, one arm was chemo alone, one arm was chemotherapy with amivantamab, and one arm was chemotherapy with amivantamab and lazertinib. Now that combination proved to be a little too toxic, and it turns out the lazertinib didn't really add anything. But the addition of amivantamab to chemotherapy, again, significantly improved progression-free survival. That regimen is not yet approved by the FDA, but it is listed in our NCCN guidelines as an option after osimertinib, and it is a regimen that I've used. You do see rash, you do see infusion reactions, but given with chemotherapy, and I give it every 3 weeks, I do think it can be a tolerable and very effective regimen. What was very interesting in that study is the amivantamab, when given the chemotherapy, seemed to provide really good coverage in the brain. And when the study was first designed, we thought, well, you really need that TKI, right? How many of us continue osimertinib long-term just to maintain control in the brain? And so when that study was designed, we said, well, you need lazertinib, you need the TKI to maintain control in the brain. But it turns out that the arm without lazertinib did just as well, and they both did better than chemo, suggesting that really the amivantamab was having some benefit in the brain. And we wouldn't necessarily expect that because it's kind of a big molecule, and so on paper it would have trouble getting through the blood-brain barrier, but it was effective, I think, which turned out to be a very pleasant surprise.
Yes, I agree with that. I think initially the thought was that with amivantamab and lazertinib, the lazertinib was really going to be the one that caused the CNS penetration. And I think we were pleasantly surprised. I do just want to quick piggyback back to, I guess you could think about sequencing, because we still don't know what to do with patients that have progression on osimertinib, whether that's progression on osimertinib plus chemo, whether that's progression on, on OC alone. And I think you have to be very judicious as a medical oncologist and also as a patient about what you choose, right? Because if you get everything but the kitchen sink up front, sometimes I can limit what your options are going forward, right? Sometimes you can't have received IV chemo. Sometimes you can only go on a study if you've received, osimertinib alone or two lines of therapy. So I think, antibody drug conjugates, which is our next topic, I think is an interesting space here. And the first antibody drug conjugate that I think we're going to talk about once we hear a little bit about what the mechanism of these drugs are is a HER3 drug, patritumab deruxtecan. And there may be some efficacy of giving this drug after osimertinib alone. So I think let's move on to antibody drug conjugates. That seems like the natural way that this conversation is going. Hear a little bit about the mechanism of action, and then we can dive into some of those topics.
Yeah, antibody drug conjugates are used a lot in breast cancer, bladder cancer, just coming into the forefront for lung cancer, and it's a novel class of drug that kind of combines a couple of different forms. These are engineered molecules, and that's really what drug development is today. In the 1970s, 80s, we were just kind of repurposing things we had, looking at things in nature, tree bark, things from the ocean. Now we're engineering molecules, and it is synthetic biology and medicinal chemistry that's really devising the drugs we need to do exactly what we want them to do. And so drug development is getting a lot more rational, a lot more intelligent, a lot more intentional. Antibody drug conjugates are a reflection on this. So there are three parts to an antibody drug conjugate, or an ADC. One is the antibody. The antibody is typically a monoclonal antibody, IgG, that will bind to an antigen or bind to a protein that is present. Ideally, you're binding to something that is present on all of your cancer cells and not present at all on normal cells. And that antibody is providing your selectivity. So that's going to hone this drug in, ideally, on only the cancer. On the other end of the molecule, you have the payload, or the warhead. And this is what's ultimately going to kill that cancer cell. Now, right now, it's mostly chemotherapy molecules. But it could be anything: an immune molecule, a small molecule, a radioisotope. It could be lots of different things. Right now, it's mostly a DNA damaging agent that's kind of like chemotherapy. And then you have a linker that puts them together. And that linker, that's the proprietary part, the trademarked part. That's the part that's sort of worth billions of dollars. Because now you've got this long molecule with an antibody over here and a payload over here. And as long as they're linked, that drug shouldn't do anything. It's inactive. It's sort of a prodrug. Once the molecule binds to a cancer cell, it gets sucked into the cancer cell. The linker then dissolves because the inside is different. Maybe it's because the pH is different. Maybe it's because certain enzymes are present inside the cancer cell. But the molecule breaks apart inside the cancer cell. And once it's broken, now that chemotherapy portion is active and destroys the cancer from the inside out. And as it breaks open that cancer cell and it dies, extra molecules are then released to kill any cancer that's around it. We call that the bystander effect. And so ideally, it is a heat-seeking missile. It's a molecule that should bind only to the cancer cells, get sucked in, destroy that cancer cell only, and not have any effect on the normal cells. It turns out it's a lot more complicated than that. That's overly simplified, and maybe it's not exactly how they work at all, but on paper, this is a type of treatment that sort of combines a targeted approach with the antibody with a cytotoxic approach in the chemotherapy.
I don't think that was oversimplified at all. I feel like that was very comprehensive, Stephen. I tell my patients it's almost like the Trojan horse, and I think you've heard me say this before, where you have this innocent looking, inactive molecule, and once it binds, it comes in, and all of a sudden the army gets released. And that's kind of the visual that I give my patients to sort of think about when, these antibody drug conjugates are getting infused. But yeah, I agree with you. And there's a question in the chat actually about the payload. Rather than it being a chemotherapy agent, why not a tyrosine kinase inhibitor?
Yeah, absolutely. It can absolutely be a small molecule, and those are being explored. It can be an immunostimulatory agent. Those are being explored. There are lots of different possibilities. Think of it as sort of a platform, chemotherapy 2.0, where we can really hone this in, but it can be used for lots of different things. We have to think of where it makes sense, where it gives an advantage over a TKI alone. And that's sort of where the beauty of drug development is. But it holds a lot of possibilities in terms of what we can put on there and how we can target these drugs selectively. There are conditional pro-body drug conjugates, which only turn on when they're in a cancer microenvironment, which provides even more selectivity. So we're just scratching the surface, but there's going to be a lot of excitement in this space. And there has been a lot of excitement, maybe a little bit too much actually, because we've seen some mixed results so far.
Yeah, I think there's like over 300 antibody drug conjugates in development right now. So I can't even keep up. But I did kind of go through everything that was presented at the beautiful targeted therapy meeting and sort of cherry pick out a couple of the high yield targets if we can kind of go through bit by bit. I think everyone knows about the antibody drug conjugates that are approved in the HER2 space, or that we use in the HER2 space, TDXD and then TDM1 that's getting looked at in protocols. And I don't want to belabor this discussion on that. I think we should talk about maybe some of the other newer agents And I touched upon HER3, which is getting a lot of buzz in the post-osimertinib setting, her patritumab deruxtecan. Do you think you could talk to us a little bit about this HER3 targeted antibody drug conjugate?
Yeah, sure. Patritumab deruxtecan or deruxtecan, we'll call this HER3-DXd. The antibody here is HER3. HER3 is a member of the ERB-B family, and these receptors are very commonly expressed in lung cancer. HER2, we know from breast cancer and from lung cancer. HER1 is EGFR. That's another name for EGFR. So here we're talking about HER3. And it just turns out that HER3 is highly expressed on lung cancer, in particular EGFR mutant lung cancer. Now, these drugs will bind to HER3, and if the cancer cells have a lot of HER3, they'll attract a lot of drug binding. It is not a HER3 mutation, and the HER3 doesn't actually seem to be doing anything to cause resistance to osimertinib. It just happens to be there, and this drug kind of takes advantage of its presence. It leverages the expression. It doesn't really matter what it's doing. It just matters that it's there and gives the drug something to bind onto. And so this is a HER3 antibody. There's a cleavable tetrapeptide linker and then a topoisomerase 1 inhibitor, which is sort of very common to a lot of older chemotherapy drugs we have. This is being studied primarily in EGFR mutant lung cancer after osimertinib. And in early data that largely came from your institution is what we see are pretty encouraging efficacy rates. We see the response rate overall was about 40%. Now, when we say response rate in a trial, as you know, that means a significant reduction in size by about 30% decrease in volume. But in terms of some decrease, the majority of patients had some decrease. And the progression-free survival there was about 6 months. The duration of response was quite impressive, and the survival a little bit over a year. What was interesting, and maybe a little counterintuitive though, with the HER3-ADXD, if you told me what is going to be the biomarker here, it's going to be HER3 expression. You've got an antibody, and so the more HER3 expression you have, the more the antibody will bind and the better it will work. But it turns out, and worked mostly, again, from Memorial, that that's not the case, that the amount of HER3 that was there did not predict how well it worked. What was also interesting is this drug seemed to work across lots of different resistance mechanisms. So if osimertinib stopped working because of MET amplification, this drug worked. If it stopped working because of a KRAS mutation, this drug worked. If it stopped working because of a new EGFR mutation, this drug worked. And so this has sort of this appeal of this empiric drug that you can just kind of reach for, and it worked across the board, which was pretty exciting. But there are side effects. And even though there's a targeted nature to these drugs, the side effects are chemotherapy side effects. And so you do see alopecia or hair loss. You do see myelosuppression, lower blood counts, a risk of infection. You do see nausea. You see a decreased appetite. And so when a physician is prescribing it, they need to be sure that they're giving nausea medicines before and for the patient to take home. We really have to treat this like chemotherapy. And an important side effect from a lot of these drugs is something called interstitial lung disease or pneumonitis. Now, you can see pneumonitis with osimertinib alone. That's true. But there's a slightly higher risk with these agents. Overall, though, the risk was relatively low. I think the risk was around 5%. And so you can see interstitial lung disease. Fortunately, it's a low risk. It's an effective drug across many different mechanisms.
Yeah, I think you touched upon so many important aspects of this that I think may have been overlooked, especially when designing the study, because I've noticed, I put my first patient on this study, I want to say like a couple months ago, a patient that progressed on osimertinib, and I was unprepared for the amount of nausea that the patient was having. And I think it's almost as nauseating as like a cisplatin or carboplatin. It almost required, like an extended dex taper after, perhaps even adding olanzapine, really making sure that you have Zofran on board, Reglan, Compazine, and educating your patients that there may be nausea, because patients that go from just taking osimertinib, as you mentioned, and doing great and not really relying and being tethered to the institution, all of a sudden are coming every 3 weeks, and they're either getting patritumab deruxtecan or patritumab deruxtecan plus OC. So the nausea is legit, and I appreciate that.
One other interesting aspect of this drug, though, as well as the HER2-DXd or trastuzumab deruxtecan, is, again, maybe we didn't predict this, but it does seem to work in the brain. There were responses in the brain, again outlined by Memorial, that a molecule this big, we would not think this would be effective in the brain, but it was. And there is clear CNS activity of this agent by itself.
Yes. I was very excited to see that. So your fears of, the excellent CNS penetration seen from OC can just be carried forward. And perhaps this might be something that's attractive for a patient that has CNS progression, but I do know that we have to demonstrate a stability. One thing that I do want to talk about with antibody drug conjugates as a whole is the need to visit with an ophthalmologist before going on these studies and the risk of uveitis. Have you seen this ever in your patients, or how are you explaining this?
Well, a lot of the trials do require eye visits, and a lot of that's just to sort of describe how common these effects are. Different antibody drug conjugates will have different side effects, and ophthalmologic side effects or eye side effects, unfortunately, are seen with a lot of these drugs. Sometimes it's as simple as dry eye, and a simple saline eye drop will be enough to help control things, but we can see keratitis, we can see sort of these films develop over the eyes that can sometimes affect vision, and that's scary, and that's not really a side effect we have a lot of tolerance for. My advice is to anyone receiving the drug is any new visual symptom or side effect should really be reported to the doctor right away. Fortunately, these are largely reversible as long as we sort of catch these early and hold the medicine. But right now they're being studied in studies, so we should be able to report how frequent they are and the effects of them. Fortunately, mostly reversible, not seen with all of the compounds, importantly though. But the real rule is anytime, especially with newer kinds of drugs where maybe we haven't given it to thousands and thousands of people, anything new should really be reported to your doctor.
Absolutely. And there actually was an excellent question that was sent just to me about ILD and pneumonitis in these patients. And I know we worry about it, especially when you've received OC and then now you're getting maybe OC plus patritumab deruxtecan or patritumab deruxtecan alone. How are you managing this if you notice a patient has ILD, obviously based on toxicity? And are you ever considering re-challenging? And how do you manage it, and who do you re-challenge with?
Yeah, it's a good question because it can be kind of a high stakes side effect. When there can be severe pneumonitis, it can land you in the ICU. It can really be dangerous. And so we don't have a high tolerance for it. At the same time, we also want to give drugs that are active. So it's always a balance. With TDXD, for example, the HER2 antibody drug conjugate, the rate of pneumonitis was quite high, about 25% at the initial dose. And what we found was that at lower doses, the risk of that was about half. So it does seem to be dose dependent, and something we have to watch for. I think the management really depends on the severity. And sometimes it's just something we see on a CAT scan. If we see it on a CAT scan alone, then sometimes we'll treat that, we'll hold the drug. In those cases, re-challenge, I think, is much more reasonable. But if someone is symptomatic, in particular, if someone has a low oxygen level, the risk is too high. And even if the drug is working, there's a risk that those side effects could escalate in a hurry. And we've seen people go from mild symptoms to being in the ICU just within the course of a day. So if someone is newly hypoxic, a low oxygen level, then generally re-challenge is not something that I would do. We treat that with steroids, as with many cases of inflammatory conditions, and we hold the drug, and generally we would not give it. That doesn't mean you cannot receive other ADCs. I don't know that we know that yet, but I do think that in this day and age, because it's so affordable, I generally recommend for a lot of my patients to really have a pulse oximeter at home. They run about $10 to $15 on Amazon. You can check your oxygen at home. I was encouraging a lot of people during COVID to have one around the house, and I think it can be really helpful in this setting to just have one so that you know if the oxygen levels are low and how serious things can be.
Yeah, I think that's a great point. At low-hanging fruit purchase on Amazon whenever we're getting click happy.
Yes.
There's a comment in the chat about finding lower dose efficacy, just as we did with TDXD at the 5.4 milligram dosing. Could you comment on that a little bit?
Yeah, I think there are a lot of reasons we want lower doses, and understand that drug development has really changed in the past couple of decades. Initially, chemotherapy had what we call a dose-response relationship, which meant that the more chemotherapy you gave, the more efficacy, the more activity you saw, and you were really limited by side effects. And so if someone could tolerate twice the dose, you would give twice the dose because it would work better. That's not true with immunotherapy. That's not true with targeted therapy or with really any of the drugs we're using now, where at some point you max out on how well it's going to work, and then you're just spilling over into side effects alone. So that's kind of new because we didn't see that with chemo or DNA damaging agents. It was really limited by safety. But now we know that we don't always need to give the highest dose, and that's sort of a new way of thinking. The FDA is aware of this, and they're encouraging companies to really find the optimal dose, and that is what they call Project Optimus. Project Optimus is a really caveat by the FDA saying, well, if your drug is going to be approved, you need to show us that you really explored the dosing in the right way, and that you're not just using the highest dose that's tolerated. At some point, are you only adding side effects with no efficacy? And so that's why you'll see a lot of studies now going forward, and I think the FDA is really good about doing this. You'll see a lot of studies now just looking at dose, comparing lower doses to higher doses. And in many cases, a good example is tarlatamab for small cell. As part of the requirement for that, they used 1/10 the dose. What they saw was the activity was identical. The side effects were a lot less. And so we're pleasantly surprised a lot of times where we don't need as much drug as we think. And so I think we're moving in the right direction. It's a good trend to be seeing.
Yes. I'm going to move us on to our next ADC target, TROP2, which I think is seen actually. When I kind of did my research, I ended up doing an ADC talk. I learned so much. I didn't realize it was exposed on almost 90% of lung cancer cells and had such a poor prognostic factor. So I know that there are some drugs that we're exploring in this space, datopotamab, deruxtecan, and a couple others, and very similar to patritumab deruxtecan, where the efficacy was irrelevant of HER3 expression. Similar to datopotamab deruxtecan, the efficacy is irrelevant to TROP2 expression. But can you talk to us a little bit about TROP2 and when should we be looking for this expression in a patient? And should patients be asking, do I have TROP2 expression? And is there a study for me?
Yeah, it's a good question. This started in the breast cancer world, where these drugs showed a little more activity, and an antibody drug conjugate targeting TROP2 called sacituzumab govitecan was studied in breast cancer. And I remember I sit on the scientific review committee for Georgetown, and there was a breast cancer trial that was developing this. And it was a chance for me to educate myself, where I looked at the drug, saw how it was designed. I said, well, why are you only giving this to cancers that have high TROP2 expression? It doesn't make sense to give it if it's not there. And so it really should only be in cases where you have high TROP2 expression. And wouldn't you know it, they had clear data that showed it kind of didn't matter. Another case where the intuitive biomarker and what we think should be the biomarker isn't the biomarker. And again, maybe implying that these drugs might work in a little different way than we think. TROP2, as you mentioned, is highly expressed in lung cancer, but its expression does not seem to predict the response to these drugs. And so as of today, we're really not testing for TROP2 expression. I think that there is going to be a biomarker to guide this, but it's probably not going to be as simple as measuring the amount of protein on the outside. There are probably some extra pieces, some extra variables that we're not sort of counting, like the concentration of receptor or how quickly those receptors are being internalized. I think it's going to be a little bit more complex, but TROP2 is an important target because it is highly expressed. And the drugs we have, these seem to have activity here. Two drugs that are pretty far in development, there are others, but two that are far in development, datopotamab deruxtecan and sacituzumab govitecan. These drugs are extremely fun to say. They have really complex names. But both of these drugs have shown some activity. When we give them by themselves, the chance of major response is probably somewhere around 17 to 25%. So not a huge response rate, not like an EGFR inhibitor, but some clear activity and stability in the larger group. When we give them with other agents, those response rates go up. Now, where we should use these drugs is a little bit unclear. They work. There's clear activity. Is it better than the standard treatment? Well, TROPION-Lung01 was a study that compared the TROP2 antibody drug conjugate datopotamab deruxtecan with our standard second-line chemotherapy docetaxel. And what it showed was the chance of response was about double what we saw with docetaxel. Progression-free survival, though, was only a little bit better, and it didn't seem to change the overall survival, which was disappointing, especially because these drugs had been built up so much. Now, in that study, if there was a non-squamous histology, something like adenocarcinoma, well, the drug actually did pretty well. It did a lot better. And if it was a squamous histology, well, the drug was actually way worse than docetaxel. We don't know why. And we haven't seen data for the other drug, sacituzumab, but we know from a press release that it also did not beat docetaxel in terms of overall survival. So we'll wait to see what those data look like and how close they were, and if there's clues as to where these drugs might work a little bit better. But where we think they hold the most promise is in the frontline setting, in combination with immunotherapy. One of the things that antibody drug conjugates do is they also can stimulate the immune response. And if that is the way these drugs are going to make their impact, then it really should be given as part of the frontline treatment. And there are several clinical trials looking at that, or that have looked at that, which may show a little bit more promise. Relevant to some of the other subtypes, there does seem to be a high chance of response in cancers that have a driver alteration. So something like an EGFR mutation, for example. An EGFR mutant lung cancer, after a drug like osimertinib, the chance of response to datopotamab was actually about 50%, pretty high response rate. That was in a single-arm study called TROPION-Lung05. So there's something about an EGFR mutant lung cancer where the TROP2 antibody drug conjugates seem to work a little bit better. And we need to further define that. But these drugs introduce other side effects. We see ocular side effects, as you mentioned, we see stomatitis, which is sort of a ulceration on the inside of the mouth. And we can't see pneumonitis or interstitial lung disease. So there are important side effects with these as well.
Yeah, I think you bring about a very important part about TROP2 and EGFR, and I think that is a space that caught my eye, and I was very surprised to see that, but intrigued. I think, so just moving a little bit away from the two antibody drug conjugates that demonstrate response irrelevant of expression. CMET and MET in particular actually was opposite that, right? So we know Teliso-V and some of the other drugs in this space, actually the higher CMET expression that you had, the more benefit that you gained. Could you talk to us a little bit about that?
Well, we haven't seen a lot of data yet for telisotuzumab vedotin or Teliso-V, but you're right. The biomarker being developed there is high CMET expression, and that's kind of the biomarker that makes sense, which illustrates the point that it's probably different for every drug, different for every target. But for MET, that high expression did seem to correlate with response. And in tumors that had high expression of CMET and adenocarcinoma histology and no EGFR mutation, so a lot of ifs, but there the response rate was over 50%. We haven't seen the full data from the phase 2 trial, but there was a press release saying that it was a positive trial. So we're excited to see it. Hopefully we'll see it in the next few months.
Yeah, I think it's so fascinating to me that the variations that we're seeing across these antibody drug conjugates and with these various markers. So still more to know. And I don't know if this is going to be, the next wave, or if there's just a lot of excitement about it, and that will be it. So stay tuned. I'm seeing, sorry, go ahead, Stephen, sorry.
Just one quick point to build on that. All these details are so important, and it makes everyone's job a little bit harder. Telisotuzumab vedotin is targeting MET, and the biomarker will be MET expression, which is different than our current oral MET targeted drugs, which are approved for MET exon 14 mutations. And so even though the gene MET protein, that MET is the same, it's different biomarkers for different drugs. So again, time and time again, the details really matter.
Yes, also same thing with MET amplification. So we can get lost in the jargon. So it's really important to kind of hone it down with your medical oncologist to see, what have you developed resistance to your EGFR, frontline therapy because you developed a MET exon 14 alteration? Is it MET amplification? Are you looking at, an antibody drug conjugate protocol because of CMET expression? There's a couple questions in the chat, and I just want to make sure that we address them. There have been a couple comments asking if we're going to be talking about any developments in the ALK space, and I didn't have anything planned, but if there are specific questions, we can go ahead and we can try to answer them at the end. And if we don't get to them, I can do my best to make sure that we get them answered for you, and Courtney can get them sent out onto the LCRF website. I see a question here about a way to determine if there is a therapeutic level of TKI in someone's bloodstream and absorbing enough to become efficacious or not enough.
No,
I don't know much about this.
Not yet. Individual pharmacokinetic studies aren't really sort of mainstream yet, and we're not entirely sure that the levels are important for activity in individual patients. So we're not quite there yet, but it's a good opportunity to mention that some drugs do impact the absorption of medicines, and a common one would be proton pump inhibitors, which we take often for acid reflux, and those can impact the absorption of some of the targeted drugs we take. So we want to be careful of potential interactions with our targeted agents.
Yes, making sure that you know exactly how to take your oral agent is super important. There's a very good question about determining MET expression and what the cutoffs are on immunohistochemistry. Could you comment a little bit about that in regards to CMET, which I think is what the question is asking?
Well, it's kind of still evolving. And so while they use certain cutoffs in the study, we have to see how those data are broken down. It is not currently a standardized test. And a lot of MET expression are what we call sort of lab derived tests, but there's a little bit of variation from lab to lab. A lot of these targeted studies are done with what we call a companion diagnostic biomarker, in which the company, at the same time as studying their drug, they study the test that sort of tells you if this drug is going to work or not. And those are the approved companion diagnostics. If telisotuzumab vedotin is good enough to be approved by the FDA, it will be approved with a companion diagnostic that will tell us exactly not just the cutoffs, but what the antibodies we should use are, how long they should be incubated, at what temperature, all these details that influence whether that biomarker is there or not. So all these details are important for a pathologist, and those details are largely addressed before the medical oncologist even sees the patient. But the FDA will have a role in making sure that the tests are done properly, and that'll be part of the approval.
Yes, absolutely. So well explained. So actually, we are in a way discussing ALK in the early stage setting, which I don't think is what everyone is looking for at this time. And I'm happy to answer questions to my best ability when at the end of our talk. But we're going to move a little bit to the early stage setting and talk a little bit briefly about some of the new approvals in this space and some of the protocols that we're looking to explore. So I know based on the Checkmate study, nivolumab plus chemotherapy was approved to be given in 3 cycles for patients with early stage non-small cell lung cancer. Then they go on to receive resection. But there's been some data that came about do patients need more after they get this induction therapy with immunotherapy? And this comes up in clinic all the time now that we're giving chemotherapy and immunotherapy as induction for our patients. After they, come back from surgery, we're reviewing the surgical path and they're wondering, well, do I need anything else? And how do you decide in these patients if you give them more immunotherapy or not?
It's a tricky situation. One of the ones where, ask 5 oncologists, you'll get 6 answers, right? The studies are approved and there are approved regimens out there, but they are a little bit different. And so this, to be clear, this is primarily for patients whose cancer does not have an actionable alteration. So we're not talking about EGFR or ALK, really talking about these wild type tumors where immunotherapy is known to play a role. And in that setting, for a cancer that's involving lymph nodes, for example, our historic standard was chemotherapy first, and then surgery to remove that cancer and then hopefully cure that patient of their cancer. And so this is for earlier stage cancers. What we saw from Checkmate 816 was the addition of nivolumab, a PD-1 inhibitor, to chemotherapy, increased the chance of a complete response, meaning that when they did the surgery, there was only scar tissue left, only fibrosis, no cancer at all. It increased the chance of that to about 24%. It's a pretty high number. And it helped prevent recurrence or relapse of the cancer. So that became a standard approach. But it was only 3 doses of nivolumab before surgery, and it just seemed like not a lot of immunotherapy. After radiation, we do it for a year. In the metastatic setting, we'll do it for 2 years. And so 3 doses only seemed light. The subsequent studies gave immunotherapy before surgery and after surgery. And that consolidation or adjuvant portion went on for sometimes up to another year after surgery. Those studies, one of which is approved, called Keynote 671, which looked at pembrolizumab, did show that you help prevent that cancer from coming back. And Keynote 671 did show that there was an improvement in survival. Now, the neoadjuvant only approach has not yet reported a survival benefit, but that's largely because it was a much smaller study. The pembrolizumab study did show survival is better. There are a lot of pretty convincing data that show if you achieved a pathologic complete response, meaning at surgery there was no living cancer left, but those patients did really well if you leave them alone. Is there any benefit to giving more immunotherapy? We don't know. And that study hasn't been done yet. It's talked about a lot, but it hasn't been done. And certainly if we don't have a complete response, I think the standard approach would be to continue immunotherapy as long as it were well tolerated and not toxic because of that survival advantage. If you have a complete response, is it necessary? I think some of our colleagues like Patrick Ford at Hopkins would say, no, it's not necessary. Whereas others like Marina Garasimo of Chicago would say it may be necessary. And I think that we have to admit that we don't know the answer yet. Certainly we want to avoid harm, and if there are side effects, we stop. But I think either approach is accepted. In my own clinic I will tell you that I favor continuing the immunotherapy afterwards. And I think your colleague, Dr. Jamie Chaff, maybe doesn't agree with that. But for me, there's just too much uncertainty, and I'm a little hesitant to withhold that treatment. So it really is my preference, my default, to kind of continue that treatment long-term after the surgery as well. But I'm waiting for a little bit more data to come out.
Yes, I think I may be skewed by my mentor a little, but I do have some thoughts of my own, and I know the Empower 010 study looking at adjuvant atezolizumab, which basically looked at patients that had, resected lung cancer and received adjuvant chemotherapy, then went on to receive adjuvant atezolizumab or placebo for a year. And there did seem to be a benefit in those that had high PD-L1 expression. And I'm not sure it's appropriate to sort of extrapolate this data into patients that received induction therapy and then got resection. But it tends to kind of skew my discussion a little bit. So if you have someone that had induction chemotherapy and immunotherapy and had a very high PD-L1 expression, maybe did not have a complete pathologic response and had, a lot of live tumor, you could say, on the chunk of tumor that was taken out, then, perhaps that might be someone that I would say it might be worthwhile to go for a year of adjuvant immunotherapy on the back end. Or perhaps someone that has a high tumor mutation burden and someone that has a heavy smoking history. We also know anecdotally that these patients tend to gain more of a benefit from immunotherapy. So I really tailor my discussion to each patient, and I wouldn't say it's one size fits all. And I don't blanket offer immunotherapy for a year to anybody that has completed induction chemotherapy and immunotherapy, and especially not patients that all of a sudden were found to have a driver alteration. So that kind of leads me towards our next topic, where we're looking at induction therapy with a targeted therapy added, right? So the Nautica and the Neo-ADAURA study. Since there's been a lot of buzz about ALK, could you talk a little bit about Nautica first, Stephen?
Sure. Neoadjuvant or treatment before surgery can accomplish a few different things. And, when we think of targeted therapy, what role can it play? Well, the targeted drugs compared to chemotherapy and immunotherapy are going to have a much higher response rate. And so if someone has a large ALK fusion positive lung cancer that we can resect, if we give an ALK inhibitor like alectinib, we're going to shrink it. Almost certainly that tumor is going to get smaller with an ALK inhibitor, and that might make the surgery a little bit easier. So should we be doing that before surgery? Is there some added benefit? And those studies are ongoing. The early results show that complete response that we see with immunotherapy, we don't usually see that with the targeted drugs, that the cancers get smaller, but we don't see these complete responses. And, is it something that's adding benefit? I think it's not clear. Right now, if someone has an ALK positive lung cancer that can be resected, it's generally our preference to resect it. And giving the ALK inhibitor up front may make it a little bit smaller, but our institution generally does not believe it changes the surgery. And so if up front you needed to have an entire lobe removed, if we make it smaller to the point where it's not in the whole lobe, maybe it's in a small part, to us the surgery is the same. Anywhere the cancer once was is an area that needs to be removed. And so we don't generally change our surgical plan based on the response. Those studies would need to be done. And so in that sense, we don't think we can change a cancer from an unresectable cancer to a resectable one. It is worth asking, and there are important studies that'll help answer that question. But as of today, we decide if something can be resected at the beginning. And if it can, we resect it, and we generally would give targeted therapy afterwards. Osimertinib approved afterwards from the ADAURA study. Alectinib will be approved at some point after surgery based on the ALINA study that was presented at ESMO. In the neoadjuvant setting, I think it's largely a research question. But here's why I think those studies are really important is not so much to get a response and to make the surgery possible, because I think it should have been possible from the beginning. But it's important from a research standpoint to understand why don't we have a complete response. If we start off with a 5-centimeter tumor and we give an ALK inhibitor, alectinib, lorlatinib, brigatinib, and it shrinks down and kills 90% of the cancer, and we cut it out, and all that's left is 10% of the cancer, now we have a chance to understand how is that 10% surviving? How are some cells surviving these ALK inhibitors, and use that information to better inform our frontline strategies in the stage 4 setting. If we say, well, only 10% of the cancer survived, and this 10% survived because they express MET amplification, well, then maybe we should give an ALK inhibitor plus a MET inhibitor, and maybe that's going to lead us down the path of curing a stage 4 with targeted therapy. Now, it's not MET. I know it's not MET, but it's something. And so if we can better understand this residual disease, how do cells survive, then we can better inform our frontline options and hopefully someday lead to more cures. That's the type of research that I think is potentially transformative, and the type of research we need to focus on, and not necessarily to improve the surgery in this one individual patient, but to better understand how these cancers are surviving through the drugs we have so that we can make better drugs.
Yeah, I think you hit the nail on the head. Like getting a pathologic specimen can offer so much insight, right? Because a lot of times we're dealing with little morsels of tissue, areas that have progressed in a patient with unfortunately advanced metastatic disease. You're not getting the full picture. You're not getting the entire tumor microbiome. So there's so much you can learn, not only about, resistance, but, are there interleukins around the area? Are there other tumor markers? Is there something that could have been predictive or prognostic about their response? And is there something about that tissue that can tell you, oh, this patient never should have gotten, alectinib, lorlatinib, brigatinib, whatever in the, as induction, or they should have gotten lorlatinib because this patient had already had the G120R resistance alteration, and there'd be so much a wealth of knowledge. So I love that you brought that up, and I'm so interested in that aspect of it as well. So thank you. But I agree. I think more to come, and I don't think we know enough. But I wouldn't say that that's a deterrent for me to enroll patients in this study, because if we don't offer this option, we don't know if it will end up being an option, and we won't be able to pave the path for others.
Agreed.
So I think we're going to move on a little bit to just the immunotherapy setting, just because there's been so much hype about these vaccine therapies. I literally get 1 or 2 patients a week that come to clinic that ask me if they can get a vaccine. What are your thoughts about this? I know our melanoma counterparts have had a lot of success, and some of the GI colleagues now, and talk to me about if you think there's a role for this in lung cancer, and any experience you have.
I mean, it's been studied so much in lung cancer, we're not willing to give it up, because on paper it really should work well, especially in someone who's had surgery, or maybe we can prevent relapse. But vaccine therapy has been pretty disappointing so far. If you recall, there was a lot of excitement over a vaccine that was being developed in Cuba. I think a lot of people were asking about it, and we know that the results from that, when that was formally studied, were quite disappointing. Vaccine therapy really relies on a unique protein that's expressed by the cancer that our immune cells can target to, but that's not expressed on normal cells. And while there are some cancers that sort of express those types of proteins, lung cancer can be a little bit more challenging. There's been a move towards personalized vaccines, which really build the peptides they target from the tumor that's already there. Those are very difficult to make. There have been multiple studies looking at the feasibility of doing that, and we have some early inroads, but they have also been a little bit disappointing, because it's more than just recognition of a peptide, which is difficult. It's mounting a long-lasting immune response, and there are some barriers, there are some inhibitory signals that really prevent that from happening in the context of lung cancer. So the immunology of lung cancer, the microenvironment of lung cancer is a little different from other cancers, which make vaccine therapy a little more challenging in particular. But we're not going to give up on that, because it holds a lot of potential. I think the same can be true with cellular therapies, where, when we look at cell therapies in hematologic toxicities and in melanoma now, they show a lot of promise. And these are high risk, high reward types of treatments where there's a lot of side effects with those therapies, but if they work, they really offer the chance to work remarkably well, in some cases indefinitely. And it's more of a personalized form of immunotherapy. And some of the cell therapy work done by our colleague Ben Creelan at Moffitt really showed that this is maybe a way to develop an immune type therapy in an EGFR mutant lung cancer and types of cancers that don't respond to immunotherapy. They're very labor intensive. They're a little bit dangerous. They require inpatient hospitalization, high doses of chemotherapy. There's a lot of risk involved. And so we have to be really certain of the reward that's associated with it to justify that risk. These studies move slowly, as they should. And so we're involved in some of those trials here, and I know you are as well at Memorial, but the progress is slow because the risk is high. In the future, my hope is that this is how we're going to treat these in a more personalized approach, but it is not an easy treatment, and it's certainly not for everybody.
Yeah, and I think it takes a lot of planning, and a lot of coaxing and a lot of, commitment from the patients to be able to get admitted. There's a lot of pre-planning that needs to happen. And as you know, unfortunately, a lot of times with this nasty disease, there really isn't time to plan. And a lot of times you need to know what your answer was, and you need your next move. It's like playing the most complicated partner in chess. You need to know 10 moves ahead, and if that 10th move doesn't work, you need to know 5 moves after that what to do, and it's almost impossible. So I really appreciate your in-depth explanation about vaccine therapy, and I think I'm going to take some of those pearls back to clinic when I get asked about it, because I struggle with how to explain such a complicated thing to a patient, and how there really isn't all that much data at this space yet. There was one submitted question. I know we have a little less than 10 minutes left, so I want to make sure that I get to the submitted question and some of the questions in the chat. There was one submitted question about KRAS, which is a hot topic, specifically in the non-KRAS G12C setting, right? So we have a lot of studies in development in the KRAS space, specifically looking at KRAS G12X, meaning KRAS G12A, G12, G12D, G12V. And the specific question is asking about anybody with a KRAS G12V alteration. Any new trials showing promise, and how can we direct these patients?
Yeah, a couple things on that. So, when we think of KRAS mutations, those are very common in lung cancer. And the most common is KRAS G12C. The C stands for cysteine. And we do have 2 drugs approved by the FDA, sotorasib and adagrasib, that are approved for G12C. They will only work for G12C. It's not that they work a little bit for G12V. They will not work at G12V at all because they bind to the C. They bind to the cysteine. So we have to know the details there. Which KRAS mutation we're looking at. Those drugs can be effective. They are approved in the second line setting and beyond because immunotherapy can be very effective in a KRAS mutant lung cancer. And there are people that in my clinic that I think are cured from immunotherapy from KRAS mutant lung cancer. So I think everyone with a KRAS mutant lung cancer really deserves a shot at immunotherapy first. There's a little bit of research ongoing now into looking at different forms of immunotherapy for KRAS mutant lung cancer. Should we be using a CTLA-4 inhibitor? Does it matter if there are other extra mutations with KRAS like STK11 and KEAP1? And so we're trying to figure out the best form of immunotherapy in a KRAS mutant lung cancer, but the frontline treatment should be immunotherapy. For G12C, we have 2 drugs approved. We have many others in development, and that's the most studied because it's where we made the first breakthroughs and because it's the most common. Next most common will be G12V, followed by G12D. G12D of note is a little more common among patients with a KRAS mutant who have no smoking history because it's not really related to tobacco use. But G12V and G12D are other very common KRAS mutations. And are there drugs that can bind it? Well, they're different drugs, but there are. And I think the one that's sort of the furthest along and maybe has the most excitement is a drug from a company called Revolution Medicines called RMC 6236. And this is another drug that was largely developed at Memorial from our colleague, Dr. Catherine Arbour and Greg Riley. But this is a pan-KRAS inhibitor. Most of the data are from G12V and G12D, but on paper, it should also work for G12C. But there are what we call pan-KRAS inhibitors that are early in development. The presented data, I think, are pretty encouraging and they look good. Not to the point where I would say this is a frontline treatment. I still think immunotherapy is the first line treatment for the KRAS mutant lung cancers. But if the question is, are there KRAS G12V inhibitors on the horizon? They are in the clinic now in trials. And if I had a patient with a G12V lung cancer where immunotherapy didn't get that long-term response, that's the type of trial I'd be looking for with one of these pan-KRAS inhibitors.
Yeah, I agree with that, and I agree with the efficacy with immunotherapy first. Another thing that we think about is, there's many different alterations that can happen in the RAS pathway, right? There's MEK, there's ERK, and sometimes we're seeing that a patient may not respond to frontline therapy or even second line therapy with a KRAS inhibitor because they're having what we call downstream alterations. So sometimes you need to have a pan-RAS inhibitor plus a MEK inhibitor. MEK is downstream from KRAS, or an ERK inhibitor. So it's KRAS and the RAS pathway is extremely complicated and tricky. And anytime we think we've just outsmarted it, we realize that there's some other molecule down in the pathway that has another alteration that we didn't think of or that we need to inhibit. So it is far more complicated than EGFR. And ALK and ROS1 and some of the other targets that we see in patients with light to no smoking history. But yes, if you have a KRAS alteration and it is not KRAS G12C, do not lose hope and do not think that there isn't something out there for you, because if there isn't right now, there very well will be soon. So ask about your clinical trials. I want to make sure I get to these questions in the chat. I see that there's a question about an ADC enfortumab with Pembro and impressive results in urothelial. Do we know similar studies in the thoracic space? Oh, sorry, go ahead.
No. Unfortunately, that's not a protein that's expressed really in lung cancer, but there are other agents that are being developed. And so that's not one that I think would have a lot of activity in lung cancer per se. But certainly we are interested in different types of combinations like that.
Yes. And there's another question here about following ctDNA to tailor initiation and duration of adjuvant IO. And I think this is another hot topic that I'm looking forward to hearing about. Could you speak a little bit about this?
Yeah, I mean, this is what the hope is. And when we look at the early stage setting, whether it's after surgery or after chemotherapy and radiation, the real question we want to start with is, are patients cured? Is someone completely cured of their cancer? And CT scans, PET scans, MRIs, they're not sensitive enough to tell us that. And that's why after surgery, a CT scan can look completely clear, but 6 months later, that cancer comes back. That means that patient was not cured of their cancer, but we didn't have any way to detect whether that cancer was still there. A test to find out if cancer is still there is something we would call a minimal residual disease test, an MRD test. And blood is a natural way to do that test. And so ideally, we would have a test where after surgery, we could do a blood test. And if the test showed there was zero cancer, that patient would not need anything else and could go on their way. And if it showed that there was some cancer left, well, then we think about immunotherapy, chemotherapy, targeted therapy, some new type of treatment to try to eliminate anything that's left. But we want to spare people who are already cured from any unnecessary treatment. But we don't have that test yet. Blood makes sense, and ctDNA is a blood test that we use in the stage 4 setting. Those currently commercially available tests probably aren't good enough for this, because we're talking about a much smaller amount of related DNA of cancer material to find. And so the current tests in their current form probably aren't good enough to really guide therapy after surgery. And they're not what we call sensitive enough to really detect these small amounts of cancer that are in the body. But rest assured, there are many companies seeking to develop that, because it is a very important tool in lots of different ways. And I would expect that we'll have something to use in that space pretty soon, but not yet.
Yes. Wow. So that brings us to 4:30 on the dot. This has gone very fast. And I could talk to you forever, Stephen, and learn from you. Thank you. Thank you. Thank you everyone for joining. And thank you, Stephen, for teaching me and teaching us, in a way that's digestible and easy to understand.
My pleasure. It's always a pleasure. Thanks for being here.